Which brings us to the question, what can a dorsal rhizotomy not fix? And I think this is where the Oswald Street group was very good. So if the child has underlying endocrine problems, it's not going to get fixed. If they have an active infection, it's not going to get fixed. If their hip is dislocated or even a hip at risk, that's not going to get fixed. If they have cognitive problems or behavior problems that are from the brain damage itself, those likely will not improve too much. If they have a low IQ, they may not improve too much. And I know I said the opposite earlier, but when you remove spasticity, some things improve, some things don't. So it's not exactly straightforward, but obviously there's conditions that come outside of spasticity, including dystonias, athetosis, cerebellar features, all those different things. They don't go away. In the early days of dorsal rhizotomy in India, the surgeons who were doing it in Hyderabad, they weren't really using very good guidance or electrophysiology. So when they did the surgeries, they would section the entire nerve root, and the people who had those came out with lifelong deformities that could not be treated in any way. So it's very important to be careful whom we take, because if you take the wrong person and you remove spasticity, other problems can emerge. The most common example being a spastic dystonia. Spastic dystonia means they look like not this in a spastic pattern, but they look something like that. And when you move the body, if you look at a spastic limb, if you try to move it this way, it won't move freely, it'll move freely in this direction, usually. Right now, spastic dystonia moves properly in both directions. So when you remove the excessive tone, sometimes that can get even worse. And this is where things become a real problem. So you really want a physician trained in function to look at those things before you move into getting a surgery done, because this surgery can make those problems worse.